Okay, well, thank you very much for the invitation. I'm Dr. Marta Ibarz from Oftalvis, Spain. I work in my clinic in Madrid. I'm very glad that I've had the opportunity to participate in this fantastic study because besides the results that I'm going to show you, it has been a pleasure for me to work with this machine, and I'm going to tell you why. In this study, we have compared the surgical efficiency between the BDI's R-Evo Smart phaco machine and what I use my current standard care in my daily practice, that is the Centurion Gold. So the objective of this study was to assess the efficiency equivalent and objectively compare the energy delivery time and fluid consumption among two different phaco machines, as I've already told you. I want to remark that the Alcon Centurion was the gold version, not the silver version. So during methods, in every patient, we took the data about the cataract grade using the LOX3 grading standard and recorded a US time, ultrasound time, and fluid consumption. I'm going to explain how we did that. The overall target of this study was 100 patients per machine and site. We have actually increased that number and will probably be 140 per site. There's two sites, one is Madrid and the other site is Alicante. These results are only from Madrid. And this is and the Excel that we use to gather all the data. On the above, you can see Alcon Centurion, and it's just the settings that I'm going to explain you later. But it's active fluidics cassette, balance tip, ultra sleeve, 2.2 millimeter incision, and coaxial irrigation aspiration. And below, you can see the data for R-Evo. So it's the agile fluidics that Dr. Khaled just already explained very well. 21G flare tip, a 2.2 millimeter incision, and coaxial irrigation aspiration as well. So I wanted to show you, and I wanted to remark this, because in our center in Madrid, we use 70% of my patients. I use femtosecond laser-assisted cataract surgery. So we are going to analyze in a separate group, not subgroup, of patients where I didn't use it. So you can see the results both in the whole population of the study and separated in those patients where I didn't use flags. So the exclusion criteria was in those patients where the console didn't pass the priming test and required a second one. Of course, the intraoperative complications like capsular breaks, wound burn, extremely non-collaborative patients, etc. That was not the case. I mean, I didn't have to exclude any. And pre-existing conditions, not to enter, not to be recruited, those patients, narrow pupils, traumatic cataracts, subluxated lenses, Morganian cataract, weak zonals, nystagmus, and previous vitrectomy. So in methods, this is very important to see that both machines, on the left you have R-Evo and on the right you have Centurion. You are able to record the ultrasound time, and both of them are going to count for the total time on of the phaco energy used for emulsification in each procedure. That means that if you're using with the pedal, you are in the position 3 in continuous phaco, then and you push the pedal for 10 seconds, then it's 10 seconds ultrasound time. If you just use 50% of the duty cycle, that is 50% on, 50% off, what it's both machines record is 5 seconds of ultrasound time. It's like mathematics of our children. So it's like very easy for all of us to understand. But it's very important to see that both methods, the methodology of the gathering of the data is complete. Then regarding the fluid aspirated, it was different because since Centurion gives you the total estimated fluid If you want me to repeat something, I can go backwards, okay? So the difference is that Centurion Vision System gives you the total estimated fluid aspirated. You just have to get a picture of the display. But in the case of R-Evo, we had to measure the back of each patient with a precision balance. We took the number with 2 decimals, and then we had to subtract, of course, the weight of the bag and also the weight of the liquid that was used for the priming, with a mean result of 36.42 grams per patient. So with R-Evo, these were my settings. I used one program for all types of lenses hardness, and I'm going to explain why. I think Dr. Khaled has talked about this before, but I find it like very, very interesting. This minimal stress, it's like, for me, it's just the name, release me before cataract surgery. So I find it very, very appropriate name for the system. And what it does is that the elongation of the tip is going to be always the same and what you have programmed independently of the hardness of the nucleus. That means that you're not going to lose, for instance, if you don't have that system, if the lens is very hard, then the tip cannot go through and you lose energy. Okay, so you're going to lose it. In the case of R-Evo, if you expect the tip to go this far, no matter what the hardness of the nucleus is, the tip will do what you want it to do. So that is very important to increase efficiency. This is because it has a sensor that it can tells the machine how hard is the cataract. Then, when you get to I didn't introduce a previous slide that I think I should have. It's just that I'm a very classic surgeon. I use divide and conquer. So I like to do a little group at the beginning. So in that part, I used continuous ultrasound with less vacuum, okay? But then that's like very easy to understand. But this part, when you go to remove the pieces of the cataract, this is what I think it's very important from the machine. I use the multi-burst system. That means that when you press the pedal, you have this first burst, and then there's 1 second until you have the second one. And you can hear and you can feel that it takes a little time. And that's very, very nice because it holds the piece into the tip, okay? And then once you still go on with your pedal, then the timing between the pulses goes little and little more shorter, okay, until 45 milliseconds every each pulse. And that's what is going to increase the efficacy of the emulsification, minimizing the repulsion of the piece of the cataract, okay? So that made me feel, I was like very fast and very secure. I like to go fast. I have many surgeries in one day, but I have to feel secure and everything predictable. And I felt it with this system. This is the epinucleus removal, and it's like it has like 2 phases. The first phase is the ice cold. It's called like that because you're using the minimal energy possible. That is 10% of the duty cycle. You're using energy. And then just when you're occluded with all the epinucleus material, then it goes up, but just to 25% on. And it is called this phase. It's called cold instead of ice cold. When you are released again, everything is aspirated, then you go back to cold, okay? And this optimizes this part of the surgery. And then irrigation aspiration was done with coaxial handpiece, cortex and polishing. The flow and the vacuum were both linear, and the visco extraction, the flow was linear and the vacuum was fixed. These are the settings from my actual cataract surgery with Centurion Gold. I use 40 millimeters of mercury. It's not very high, I know, but I'm a quite experienced cataract surgeon from many years ago, so I feel very comfortable with these settings. And I had the chance to have Giovanni Ferris with me to help me adapt my parameters to Revo, and it was like very successful. I have to thank him because I felt really comfortable with Revo. And these are the preliminary results that I'm going to show you. The sample were 45 patients, Revo, 45 patients, Centurion. As you can see, this is the cataract grade. It's actually kind of very comparable in each group. There's no differences. Maybe N4, I did more with Revo Smart, and N6, one with Centurion, but there were no differences, significant differences. And these are the results that I really didn't do anything different using Centurion and using Revo. It's just I am like a very boring, systematic kind of surgeon. I like everything to be all the time the same and very predictable. So using the same technique, I got like almost half of ultrasound time with Revo compared to Centurion, and it was statistically significant. And also, I consumed less fluid than with Centurion. That the difference is not that high, but it's still statistically significant. Now, we take a look about the results on just on the subgroup of the no flux in patients. The sample is quite little. Okay, we need to increase this sample when we finish all the study. But still, of course, I used more ultrasound than with my flux patients, but that happened in both groups. But I was using still less ultrasound with Revo compared to Centurion, and less fluid, but in this case, the results for fluid were not statistically significant, but maybe because the study was underpowered, because the N is very low, yet we have to do this recruit more patients and show you the results when we finish up all the study. So to conclude, the objective measurement of energy delivery and fluid consumption efficiency during lens removal and irrigation aspiration proved that Revo is an efficient and safe phaco platform. No adverse events were observed during the course of the study with any of the phaco machines. And my personal assessment, this is like very subjective, but I really want to tell you, but I didn't expect that a new phaco that I was trying was going to be better than my daily care practice. I mean, I'm very used to working with Centurion, but my corneas were more clear. My IOP spikes that sometimes I have, I'm a glaucoma surgeon too, I have many glaucoma patients, were lower. I mean, I had less number of cases. So I was pretty happy and very happy with the machine. And I have to remark that both machines were used under the manufacturer's recommendations in terms of settings for fluidics and energy delivery, as I've already explained to you. So do you have any questions? Thank you.